And today's topic is very important, rheumatoid arthritis, because majority of the patients that the PGs will get to see during their residency would be of rheumatoid arthritis. I welcome Dr. Deepak Malgutte to deliver his lecture on rheumatoid arthritis. Deepak is a MD Medicine from Sion Hospital and has done DMB Rheumatology from Apollo Hospital, New Delhi, currently working as Assistant Professor in Sion Hospital and practicing as a consultant rheumatologist. Over to you, Deepak.
Thank you, sir. Yes. So just a moment, sir. So are my slides are visible?
Yeah, they are visible.
I'll take a moment. Uh, okay. So good morning, everyone, and warm welcome to all the postgraduate medicine residents joining today. So I'll be talking about rheumatoid arthritis, which is the most commonly encountered autoimmune disease, and I'll take you through some of the clinical cases to understand how to interpret the lab reports, how to understand the pathogenesis clinical feature, and what are the treatment modalities that we have and how to differentiate between the rheumatoid arthritis and its mimic. So let's begin with this case. A 50-year female who had a polyarthralgia and since 2 to 3 years, she was obese, hypertensive diabetes. She got evaluated and her report showed raised inflammatory marker and RA factor was positive, ANA was negative. So this was her knee, which she is complaining continuously of knee swellings. So if you can see this, and with this, she presented to us uh, for she was outside considered as a rheumatoid arthritis, was given a short course of steroid therapy. So now question, sorry, the slides are not moving. Uh, Vikram sir,
Yes.
slides are not moving actually. Uh,
Is the technical person there because somebody is recording the meeting?
Yes, sir, I'm there.
Yeah.
Sir, please exit the slideshow and start again. Are you on Windows or Mac?
Windows.
Windows, right?
So,
So just exit the
stop
slideshow.
share and then again.
Yeah,
Okay.
and press F5 or there is a button on the bottom right of the screen.
Okay,
Okay, now you can press F5.
I'll reshare then.
Okay, okay.
No.
No, no, resharing is just for Zoom, but you
Uh,
need to share your start your slideshow on your machine first. Just exit that slideshow first from your machine itself first.
okay, okay.
Once the slideshow starts on your PC, then you can share on Zoom.
So, eh,
I think the machine
not
is
able
hung.
to.
Are you able to open
This
any other window?
animation has started. Can I exit that?
Fair
I
enough. No
think that
issues.
is why.
No issues. No issues. No issues. Correct. Now your screen is visible. Now you can press F5. Correct.
Okay.
Now it's going well.
Now slides are moving.
Yes, yes, yes.
Vikram sir.
Yes, it's moving,
Yes, they
sir.
are moving. Yes, it's moving.
You can continue now.
Hello.
Yeah, it is visible, Deepak. Go ahead.
Uh,
Your slides are visible.
are the slides moving now?
Yes. Yes, go to the next one. Yeah.
Hello.
Yeah, your slides are moving. We could see your introduction slide. We could see the other two slides also.
I think, sir, he's not able to hear. His speaker is off. Might be. He's not
Deepak,
able to
can you
hear our
hear me?
voice.
Vikram sir.
Yeah, can you hear me,
Can
Deepak?
anyone confirm is the slides are moving?
Yes,
He's
the
not able to
slides
hear,
are
sir.
moving.
No, sir, he's not
Hello.
able to hear. His mic is on, but his speaker is off. Maybe you should call him on his phone first.
Hello. Sir. Okay. Okay. I'll start then. So with this, she was considered as a rheumatoid arthritis. But actually, if you compare this knee swelling to opposite this another lady swelling, here you can see there is a the dimples on both the side of the knee being obliterated compared to this dimple. Or here you can also see the knee dimples. And what she is describing knee fusion is actually a fatty swelling. And what this illustrates is basically the bony swellings, which are Hubbard nodes and Boucher's nodes. So basically, she has a osteoarthritis of knee, which gets falsely diagnosed as a rheumatoid arthritis because RA factor being elevated. So that is how a rheumatoid arthritis sometimes confuses us. So what I'm going to do is I'll discuss about pathogenesis and risk factor, various articular and extra-articular manifestations, diagnostic evaluation, and treatment armamentarium through various cases. So rheumatoid arthritis is a chronic inflammatory disease which affects various articular and extra-articular manifestation. In India, the prevalence is estimated to be around 0.3 to 0.8%, and it is slightly higher in northern and urban population. The women are affected 2 to 3 times more than men, and age of onset is usually considered 20 to 40 years. And late onset RA is RA when it begins after 60 year of age, which has slight different clinical manifestation from young age onset rheumatoid arthritis, which I'll discuss later. So the treatment armamentarium, as I explained, has vastly expanded, and thus choosing a right treatment is leads to the better outcome in patients with rheumatoid arthritis. Coming to the risk factor for rheumatoid arthritis, the most important is a genetic factor which makes the individual susceptible to the rheumatoid arthritis, of which HLA-DRB1 shared epitope is the strongest genetic risk. And presence of it in a first degree relative makes 3 times higher risk, whereas in second degree relative, the risk would be 2 times higher. Other than MHC gene, there are certain non-MHC gene which can be implicated in the pathogenesis like PTPN, STAT4, or TNF receptor associated factor genes. Other than genetic factor which makes an individual susceptible, the presence of environmental factor and certain other lifestyle factor makes an individual triggered to the development of this rheumatoid arthritis, of which smoking is the most important, and it has dose response relationship. So more smoking leads to the higher risk of rheumatoid arthritis, and this risk persists despite even cessation of the smoking for up to 20 years. And it is the non-nicotine part in the smoking which has a major impact for causing the rheumatoid arthritis. Other than silica, mineral oil exposure seen in construction worker or miners has a increased risk of rheumatoid arthritis. Then certain periodontal infection, especially the Porphyromonas gingivalis, which has a pad enzyme expression, which lead to the citrullination of various peptides, causing anti-CCP positivity, has a risk factor for rheumatoid arthritis. Other than environmental factor, there are certain lifestyle factor like obesity, physical inactivity, which leads to the increased risk, and then certain hormonal factor like estrogen, because of which women have a higher risk than men. And pregnancy is considered a protective factor, but in postpartum phase there are increased risk of flares. So this is how pathogenesis goes on. So this is the various stages of rheumatoid arthritis which have been explained. In a susceptibility phase, patient have the risk factor like which I have mentioned, and this risk factor make an individual susceptible to the rheumatoid arthritis. But in the presence of these susceptible factor, when individual get exposed to the various environmental lifestyle factor, it result in the post-translational modification of various proteins causing citrullination, which result in the loss of mucosal intolerance and intolerance, which result in the autoimmunity. And that leads to the increasing levels of various cytokine and chemokine, which result in the early rheumatoid arthritis, where the immune cells start getting infiltrated into the joint synovium, and later it develops into the established RA when it forms a well-defined pannus, resulting in the articular and cartilage destruction. So this is how a rheumatoid joint actually looks from the inside. This is articular cartilage and bone, and this is synovium. So in rheumatoid joint, where there is an inflammation, the neoangiogenesis leads to the increased cellular infiltration, and there are various T cell, B cell, macrophages, mast cell, and histiocytes which are being present in the rheumatoid, and antigen presenting cell present these various new antigen to the T cell, and this T cell differentiate into the helper T cell and Th17 cells, and these helper T cell present to the B cell, which result in the plasma cell and formation of various autoantibodies we see in rheumatoid arthritis, like R factor anti-CCP. These Th cell, Th17 cell produces various cytokine like IL-17, which leads to the further production of TNF, interleukin 1, interleukin 6, which are all implicated in the pathogenesis, and they act through various pathways like signaling pathways like JAK-STAT pathway or other signaling cascade, which result in further inflammation, and this result in the pannus formation, which result into the articular cartilage and bone destruction, causing the damage and deformities which we see in rheumatoid arthritis patient. So this is the usual clinical course, and most commonly the rheumatoid arthritis being described as a insidious onset and gradually progressive additive pattern of arthritis, which is usual pattern seen in around 50 to 65% of rheumatoid patients. And these are the common joints which are involved, like small joints of hand, like PIP, MCP, wrist, then large joint like elbow, shoulder, knee, ankle, MTP joints, and sometimes cervical spine. Rest other spine joints are usually spared in the rheumatoid arthritis. Sometimes the presentation of rheumatoid arthritis, which is we consider as a chronic arthritis, can be an acute onset, which is seen in around 15 to 25% of the patient. And sometimes there are some atypical presentations, like a palindromic rheumatism, where what happens is exactly a patient develops a single or few joint involvement which lasts for 2 to 3 days, and then they get relief, and then again after a certain time they start having inflammation. So these are episodic in nature. Sometimes rheumatoid, though we call it as a polyarthritis, but sometimes they can have a mono or oligoarthritis presentation in the beginning phase. Sometimes it can be a arthritis robustus, where when you examine, you see a lot of joint swelling, joint tenderness, but patient doesn't feel pain, and it is usually seen in the heavy workers. And sometimes rheumatoid can present as an extra-articular manifestation like ILD or scleritis as the beginning feature of the rheumatoid arthritis. And the systemic symptom can be seen in one-third of the patient, which include fatigue, myalgia, low-grade fever, and weight loss. So, pattern of joint involvement helps us to differentiate rheumatoid arthritis from various forms of arthritis. So, like in rheumatoid arthritis, as I explained, PIP, MCP, wrist, elbow, shoulder, knee, ankle, and foot joints are the mainly involved. Whereas in case of psoriasis, if you see, the hand joint involvement is like sun-ray pattern, where you get involvement of MCP, PIP, and DIP joint, which so it involves in a ray pattern which is called a sun ray pattern, and the peripheral joint involvement can be symmetric or asymmetric, and it may involve the spinal joint as well. Whereas in case of spondyloarthritis, it is the involvement of SI joint and axial skeleton, and sometimes they can have a large predominant large joint involvement involving lower limb, which is asymmetric fashion. And in osteoarthritis, the hand joint involvement involves the PIP and DIP, which in contrast to rheumatoid involve only the PIP and MCP. So these patterns of joint involvement help us to identify what kind of arthritis we are dealing with. These are the some of the deformities that we see in rheumatoid arthritis patient. But nowadays, with the advance of treatment, the appearance of deformities have drastically reduced. Still, we get some patients who have deformities, and the usual deformity that we see, this is a Boitner deformity, where the PIP joint is buttonholing through the lateral collateral ligament. This is a swan neck deformity, where there is a PIP joint hyperextension followed by DIP joint hyperflexion. This is the ulnar deviation, which is the most common deformity we note. This is the Z deformity of the thumb. And sometimes patient can have a severe erosive disease, which lead to the tendon rupture, resulting in the falling of the fingers, as we can see. And it may mimic like a patient is having neuropathy and get misdiagnosed. So it is these deformities are the just tip of iceberg. And if we diagnose patient when these deformities are developed, then we may lose a large chunk of the patient. And what we need to identify is the patient who have a early rheumatoid arthritis, who have seronegative inflammatory arthritis, or patient who have a CTD or psoriatic arthritis in their initial phases. Now, as I described, the rheumatoid arthritis is not a disease which is limited only to the joint. It has various extra-articular manifestations which have been reported in around 30 to 40% of the patient, and it can extend from head to toe. So in eye, it can result in scleritis, dry eye, then it can result in scleromalacia, peripheral ulcerative keratitis, in cervical spine involvement can result in spine cord compression. The lung involvement can happen in various ways, which it may involve pleura causing pleural effusion. It can affect lung parenchyma causing lung ILD. It can cause lung nodules, and then Kaplan syndrome, which is a pneumoconiosis. And sometimes it can affect kidney cause due to the long-standing rheumatoid arthritis causing amyloidosis. It can present as a RA nodules. It can lead to the various neuropathies which are seen in rheumatoid arthritis patient. Sometimes it can lead to the leg ulcer, and so many extra-articular manifestations have been described in rheumatoid patients. And these manifestations are usually seen after the onset of rheumatoid, but sometimes they can be precede the joint involvement in few patients. And these are usually markers of high disease activity and carries a poor prognostic factor. So let's see this case, a 40-year lady with a rheumatoid arthritis who since 8 to 10 years, she was on methotrexate and HCQ, and she developed cough and dyspnea on exertion for 7 days, and her physician did her HRCT, which showed this UIP pattern of ILD. If you can see over here, what she had is the honeycombing and some reticular fibrosis and traction bronchiectasis. Her this episode of cough and dyspnea on exertion relieved within a 2 week, which was actually a LRTF. But what HRCT was showing as a ILD, and she was on methotrexate and HCQ. So, and this was her pulmonary function test evaluation, which showed a FVC of 71 and mild FUN by FEC ratio of 107. So the question arises whether we should stop methotrexate in this case and start on mycophenolate mofetil, or we should continue with methotrexate. And the earlier guidelines, which used to be say that we should stop methotrexate, and many physicians or respiratory physician believes that methotrexate should be stopped in these cases. But with now advance of various data, retrospective, prospective data, it has been concluded that there is no need to stop the methotrexate. Methotrexate very rarely causes a hypersensitivity ILD, and it has no risk of causing this UIP pattern ILD. So we should continue with methotrexate. And the different point in rheumatoid arthritis is compared to other connective tissue disease related ILD, which usually has a NSIP pattern of ILD. Rheumatoid has more of UIP pattern ILD, and majority of patients are asymptomatic, and symptomatic progressive disease is seen in only 10% of the patient. And we consider as a progressive when patient has is a symptomatic for ILD, or when patient has a FVC which is failing more than 10%, or FVC which is less than 70%, then only we consider treating this rheumatoid ILD. Otherwise, they remain asymptomatic in few of the patients. Other than lung ILD, the patient can present with rheumatoid nodule, which are subcutaneous nodule, non-tender, painless, which are seen mainly in the bony prominences, such as elbow, finger joints, ischial and sacral prominences, occipital scalp. I have seen where hardly one or two patients, and tendo Achilles region. This being reported in around 20 to 40% of patients, and the presence of this subcutaneous nodule alerts us that these patients usually have a high disease activity and high risk of having joint damage and joint deformities, and having extra-articular manifestation. Other than this, subcutaneous nodule with arthritis can be seen in patients having scleroderma, which the subcutaneous nodule could be calcinosis, or it can be seen in inflammatory bowel disease, where it can be a IBD, it can be a erythema nodosum like swellings. Other than that, ocular manifestation is very commonly reported in rheumatoid arthritis, of which most common is Sicca symptom, which we evaluate by doing Shermer test. And it is the patient usually complains of gritty sensation or photophobia or redness in their eye. Other than, we can see a episcleritis, which usually looks like a sectoral benign mild discomfort, usually painless redness in the eye. Sometimes it can lead to the scleritis, which are of various types, like it can be a diffuse scleritis, nodular scleritis, or it can be a necrotizing, which is a severe one, where it patient needs a aggressive immunotherapy. And sometimes it can lead to the peripheral ulcerated keratitis, which is again a serious condition involving the eye, where we need a immunotherapy therapy. So, other than ocular manifestation, rheumatoid vasculitis is one more, which with advance of all the treatment we have now has decreased in prevalence. But it is usually seen in patients who have a long-standing rheumatoid arthritis, and when they develop rheumatoid vasculitis, that time their articular involvement has become usually goes in remission or in a mild disease, and they have more of vasculitis presentation, which can be a small or medium vessel vasculitis. And the commonest presentation usually involve the skin, where they can present with purpura or digital infarct or leg ulcer or nail fold infarct or libido reticularis. Sometimes they can present with mononeuritis multiplex, causing foot or wrist drop or asymmetric sensory motor neuropathy. And sometimes it can cause a visceral involvement in the form of mesenteric, cardiac, or renal vasculitis, though very less commonly seen. So here the clinical call is that patient who have rheumatoid arthritis, if presents with a painful leg ulcer, or if they are presenting with mononeuritis multiplex or digital gangrene, think of rheumatoid vasculitis in these patients. Now let's see this case. So here a 44-year female who had a polyarthralgia since 4 to 5 months, and her examination showed a right second PIP and left wrist swelling. her inflammatory marker were normal, and her RA factor was positive, 60 against cutoff of 30. So with this evaluation, can we consider a diagnosis of rheumatoid arthritis? So this is a 2010 ACR ULR criteria, which is being a classification criteria developed for rheumatoid arthritis, which involve four components. One is joint involvement, serology, acute phase reactant, and duration of symptom, whether less than 6 weeks or more than 6 weeks. With this history, we see her score. She has a two small joint involvement, which equates to a score of 2. She has a low positive RA factor, which equates to 2. And she has normal ESR CRP, and duration is more than 6 weeks. So the score comes 5. And for diagnosing rheumatoid arthritis, we need a score of equal to or more than 6. So can we confirm as a rheumatoid arthritis in this patient? So basically, this is a classification criteria. And importance point is here is that rheumatoid arthritis diagnosis is a clinical diagnosis. And what this criteria is a classification criteria, which is mainly used for research or trial. And in clinical practice, what we need is a clinical judgment to identify or diagnose a patient with rheumatoid arthritis. Now, the various investigation that we do for diagnosing rheumatoid arthritis, first is rheumatoid factor. What is exactly a rheumatoid factor? It is a autoantibody which is directed against the FC portion of IgG, and it is most commonly what we identify is IgM, but sometimes it can be IgG, IgA, or IgE, and it is usually measured using earlier days it used to be measured by latex agglutination test, where a latex particle which are coated with IgG, when patient serum contain the antibodies against this Fc portion of IgG, they form immune complex which get agglutination, and we can detect them, and this is the method by which latex agglutination was done, where if you can see here there is a agglutination has been formed, and it is at the lowest concentration where we can see the precipitation. We label that as a titer. Nowadays, the better tests have come compared to latex agglutination, like nephelometry or ELISA. And the sensitivity of rheumatoid factor in rheumatoid arthritis in early rheumatoid patient is estimated to be around 50 to 60%. Whereas in established RA, where the joint damage or deformities have developed, it is seen to be 70 to 80%. So it is fairly sensitive test. And low positive RA factor is when titer is less than 3 times the upper limit of normal. And this low positive RA factor can sometimes be non-specific, as I said in the first test. Whereas the I positive RA factor is when it is more than 3 times, which is quite specific for rheumatoid arthritis. But this much high titer positivity can also be seen in some other condition like Sjogren syndrome or triglobulinic vasculitis. Another test which we have is anti-CCP, which is the anticyclic citrullinated peptide. And these are antibodies to this citrullinated peptide, which can be of various peptides like vimentin, fibronectin, fibrin, and so many. And these are considered to be a better test compared to RA factor, and they have more specificity. But still, they can be false positively seen in patients who have a psoriatic arthritis, in some other connective tissue disease like SLE or Sjogren, or even in patients who have a TB. And main important point is that 20 to 30% of patients who are rheumatoid arthritis and RA factor negative can test positive for anti-CCP. So whenever if you get a scenario where you have patient with a chronic polyarthritis and you want to do either RA factor or anti-CCP, which test you should consider doing among these? So the answer would be this answer is provided by this extensive study done by Nishimura et al., where they had looked for the sensitivity and specificity of RF factor and anti-CCP. And if you see, the anti-CCP and RF factor has almost similar sensitivity, which is around 65 to 70%. But in terms of specificity, if you see, anti-CCP is more specific, 95% compared to RF factor. So the answer would be anti-CCP, which is more specific compared to RA factor to detect the rheumatoid arthritis. And the various serological scenarios which we see in our patient is whether either the rheumatoid arthritis patient is positive for both or positive for either R factor or anti-CCP, and sometimes they can be negative for both, that is seronegative rheumatoid arthritis. Nowadays, there are some other tests which have been emerging, of which anti-mutated citrullinated vimentin is another antibody which is being now available to test in these patients who have a seronegative arthritis. And then there are certain other like anti-PAD4 antibodies, anti-carbamylated antibodies, and so many which are coming up. And the significance of these antibodies is that they determine the patient is having high disease activity. There is a risk of extra-articular manifestation or radiographic damage or a poor response to conventional DMARD therapies, or they can predict the chronic and progressive disease. Now, can we should we do these tests on a repeated basis in patients who have rheumatoid arthritis? So, answer is no. So, why? Because these have a limited role in disease monitoring. Their titer doesn't correlate with disease activity in later part of treatment. They are mainly used as a diagnostic, and they have prognostic value at the initial outset, not in the follow-up phase. So we should consider repeating only when the patient is initially negative for RA factor or anti-CCP, as 18% of patients with rheumatoid arthritis can be RA factor negative at the beginning, and 10% of patients can be anti-CCP negative, which on later can turn positive. Otherwise, there is no need to repeat if they are positive at the beginning. And sometimes what we commonly label patient having chronic inflammatory arthritis as a who are RA factor and anti-CCP negative as a seronegative arthritis. But I would consider ki you should look for some other feature which can differentiate some other forms of arthritis. So we should look for the hidden areas in this patient to look for the psoriatic rashes like behind the ear or in the mammary region or below the neck or in the groin region, anal region, or we should look for the nail to look for the various psoriatic patches. Or sometimes they can have a connective tissue disease related, CTD related arthritis, where they might be having, in addition to this arthritis manifestation, some CTD manifestation like alopecia, palatal ulcer, which are usually painless, and unless and until we see for them, we may miss it. Or presence of ILD or some other Raynaud's or some other CTD related manifestation. Sometimes it can be a chronic gout which becomes later on polyarticular, but usually asymmetric, which we may miss it. And this can be seen here as a tophi, which may mimic as a RA nodules. And sometimes chronic infection like hepatitis B, hepatitis C can lead to the seronegative arthritis. And then there is a one important mimic like leprosy, where you can here see a patient who has a polyarthritis, and this here you can see a nerve enlargement and this ear lobule infiltration. So always look for these chronic infections, and even sometimes malignancy can mimic a rheumatoid arthritis. Now let's see this case scenario where we had a 40-year female who had a low-grade fever since and arthralgia since 2 to 3 weeks. Here we can appreciate what she had a PIP and NCP joint swollen significantly. And on evaluation, what she had is a leukocytosis and mild thrombocytopenia and raised inflammatory marker and RF factor being positive. So she was started on steroid, but after starting steroid, her joint pain subsided, but her fever started worsening. She became dyspneic, and then she presented to us, where a simple auscultation suggested a murmur. And when we did a 2D co-evaluation, we diagnosed her as an infective endocarditis, which is causing this inflammatory arthritis, and this RA factor being false positive. So there are various conditions where we can get a false positive RA factor, and we need to keep in our mind. Like aging is another important factor which can lead to false positive RA factor. Then some chronic bacterial endocarditis, chronic viral infections, TB, syphilis, leprosy can lead to the false positive RA factor. Even sarcoidosis, pneumoconiosis can lead to the false positive RA factor. And in malignancies also, we can see a false positive RA factor. So always remember that rheumatoid arthritis, if you get an acute onset arthritis, it can be a post-viral. It can be some infection or malignancy which is hidden inside, and do not directly base on the basis of low factor RA factor or directly jump to the conclusion that patient has a rheumatoid arthritis, because missing these infection and starting steroid can worsen these infections. Now, coming to the treatment part, what is foremost important thing in this patient is patient education, where most important thing is we need to tell this patient that the therapy would be longer duration, and they need to take medicine very properly and do the some blood monitoring on a regular basis like CBC, liver enzyme evaluation. And many of these patients are young females, so strong importance should be given in relation to their planning for pregnancy. The medication which are safe in during the pregnancy, like methotrexate and leflunomide, should be avoided if they are planning for the pregnancy 3 months before planning. And what we can offer them is sulfasalazine and hydroxychloroquine. And that's why when they are not planning, contraceptive advice is very important in them. Now, coming to the treatment options that we have, as I discussed, is conventional demand, which include methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, and steroids. And to the add to the list, now we have igurati mode as well. And then we have a biological, which include anti-TNF class, among which there are 5 biologic, of which certolizumab is not available in India. We have anti-IL-6 like tocilizumab, which we have used in COVID era also, anti-CD20 rituximab, and anti-CTLA4 abatacept, which is still not available in India. And in target synthetic demand, which have recently been generic version has come. So we have now tofacitinib, baricitinib, and upadacitinib just recently launched in India. So among these, how do we use these medicine is the question mark. So with these various choices, we get confused, and let's see how to manage this patient. So managing the rheumatoid arthritis, the 4 P's are important. When to start treatment, time to treat. So rheumatoid arthritis patient develops damage or erosions very early within first 2 years of life, and it has been shown that treating this patient as early as possible can result in reduction in the joint damage, and even mortality has been reduced. So this early treatment gives us a window of opportunity to avoid all the complications. And treating this patient, we need a target. So we target either to get a remission or low disease activity in a stipulated time. And for that, we use various targeted therapies right now, with like biologics and JAK inhibitors. And we should use in a various treatment strategies. Either we should begin as a monotherapy, combination therapy, step down, step up strategies that we'll see. These are the common joints which we evaluate in while monitoring this rheumatoid arthritis patient, like PIP, NCP joint, wrist, elbow, shoulder, and knee, and based on which there are various scores which have been developed. I'm not going into the details of this scoring, but most easier to that you can use in your day-to-day practice is CDI, which doesn't require any calculator or any inflammatory marker. It is just a clinical disease activity index where you look for 28 joint swollen, 28 joint tenderness, and you ask for patient and physician assessment of disease activity in last 1 week, based on which we can calculate this score. And our treatment goal in this patient is to achieve a remission or low disease activity in the first 6 months. For that, at least 50% improvement should we get in first 3 months. And if we are not getting in first 3 months, 50% improvement or remission or low disease activity in next 6 months, then we should consider either adding a therapy or changing the therapy. So these are 23 EULAR recommendation for management of rheumatoid arthritis, where patient who has newly diagnosed with rheumatoid arthritis, and if they don't have any contraindication for methotrexate, like patient who have a EGFR of less than 45, or a patient who are planning for pregnancy, or lactating mother, or if they don't have any liver disease, then you can safely start methotrexate. And if they have a contraindication to methotrexate, then you can consider either leflunomide or sulfasalazine. And with the initial phase of conventional demand, we can use a short course of steroid therapy with a lowest dose and for shortest possible time, which will give us a initial time to buy. So because this conventional demand takes at least 1 and 1.5 months to start show the improvement. And what we see is improvement at 3 months and our target of low disease activity or remission to be achieved in first 6 months. And if we are getting it, then we should continue with the same therapy till we get a sustained remission. And if you are not achieving this goal in first 6 months with methotrexate or initial conventional demand, then we plan to escalate the therapy, for which we look for whether presence of any poor prognostic factor, which include any high titer RA factor or anti-CCP, or high disease activity, or evidence of joint damage, or failure of more than one conventional demand therapies. In such a scenario, then now Euler or ACR recommends directly starting either biological or JAK inhibitor in these patients. But still in India, sometimes due to the cost issues, we use a triple demand therapy here as well. And suppose if these poor prognostic factors are not present, then you can add on therapy to the initial conventional demand. Like with methotrexate, we can add either leflunomide or sulfasalazine or HCP. And then again, we look for our targets in 3 and 6 months, whether we are achieving it or not. If we are achieving, then we should try to maintain a sustained remission. But if we are still failing, even despite using either biological or JAK inhibitor, then we should consider either changing the biological therapy from one class to another, or changing from biological therapy to the JAK inhibitor, or vice versa. And still we should monitor for to achieve our targets, and we'll look if the target is achieved, then we should continue to maintain a sustained remission in this patient. Now, these are various conventional demand that we use, of which these are hydroxychloroquine, methotrexate, which is usually given as a oral or subcut formulation at a 15 milligram to 25 milligram dose, sulfasalazine and leflunomide. And limitation with this conventional demand is they take a onset of action is usually a delayed for few months, and remission is usually a partial. And sometimes there is a tendency to lose this effectiveness, which and there are risk of multiple conventional demand causing toxicities. So that's why nowadays we are preferring either biological or target synthetic demand if initial demand fails in first 3 to 6 months. And when should we consider this? When patient have inadequate response to initial conventional demand, or have a intolerance or a high aggressive disease activity, or in special situation like patient who have a scleritis or corneal melt or rheumatoid vasculitis, or patient who have a ILD. And before starting any biological or target synthetic demand, what we should always look for is rule out some hidden infections like hepatitis B, hepatitis C, and TB infection. And also, whenever we are starting this biological or target synthetic demand, we should consider patient to be vaccinated for pneumococcal and influenza. And in patient who are above 50 years, we should consider herpes zoster, a Shangrix vaccine, which is available nowadays. And there is a huge debate whether we should proceed with a biological or tofacitinib or triple conventional demand, where cost is the issue for our some Indian patients. Where we should these the various trials like RACAT trial, SWIFT trial have shown that these triple conventional demand are slower to act, but on a long-term basis, if we see, they are almost equivalent to biological or tofacitinib. So whenever cost is a concern or infection risk is a concern, we can consider triple conventional demand therapy in these patients. Now, various anti-TNF which we have is infliximab, etanercept, adalimumab, golimumab, and certolizumab. And the problem with these anti-TNF is development of anti-drug antibodies. And there are various biosimilars of these biologics are available, and they have shown to be almost comparable to these biologics. And only risk that they have is a TB reactivation, which would be comparatively less with etanercept and golimumab compared to adalimumab and infliximab. Also, the risk of malignancy is less, and they are contraindicated in patients who have a demyelinating disease or in patients who have a type 3, type 4 heart failure. Another is rituximab, which is given can be given as a monotherapy or in combination with conventional demand. and they are first choice in patients who have lymphoproliferative disease along with rheumatoid arthritis, which can be given as a 1 gram every 15 days apart for 2 cycles, or even it can be given as a low dose 1 gram. Or then there are certain trials where low dose therapy of 200 milligram has also been used for patients with rheumatoid arthritis. Another is tocilizumab, which is IL-6 receptor antagonist, which is available in either subcutaneous injection or IV injection form. And these are preferred as a monotherapy or in combination therapy, especially even in patients who have even anti-TNF failure uh, with rheumatoid arthritis. Now coming to the molecules which are JAK-STAT signal affects the JAK-STAT signaling, that is target synthetic demand. Let's see how they act. So these are various ligands like cytokines, chemokines, which attach to the receptor, which result it's like almost similar to the insulin pathway, where this ligand binding result in the phosphorylation of JAK, which causes phosphorylation of STAT molecule, and this STAT dimer molecule undergoes goes into the nucleus for translocation, where they affect the DNA and result in affection of various proteins which are produced. And that is how the JAK molecule, JAK inhibitor, we have developed. So if you can see, this JAK inhibitor can affect various inflammatory cytokine, chemokine, like all the interleukins like interleukin 2, 4, 6, IL-2, IL-23. Then it can affect various erythropoietin, thrombopoietin. It can affect interferons like interferon alpha, beta, interferon gamma, which the JAK molecule act as a ligand. And inhibiting this JAK inhibitor can result in affection of this cytokine expression and their effect. So that is why these JAK inhibitors are a very, though a small molecule, but has a big role. And also with affection of these erythropoietin, thrombopoietin, they can have a side effect like thrombocytopenia, anemia, leukopenia. Affecting this interferon pathway can result in increased risk of viral infection, like we are saying herpes zoster. Affection of this IL-6 can result in the dyslipidemia, bone resorption. All these pathways get blocked. So my drug selection in special situation. So in pregnancy, we usually give hydroxychloroquine and sulfasalazine. Where sometimes we have to use low dose steroid for shortest and smallest doses. And sometimes when the disease is not getting control, then we can use a biologics like etanercept or certolizumab. When patient have a high risk of TB, then tocilizumab or rituximab can be an option. In patient who have a lymphoproliferative disease, Ritux is an option. In patient who have a necrotizing scleritis, where you need a high dose immunosuppressive therapy like cyclophosphamide or rituximab. Even also in patient who have a RA vasculitis, we use steroid and rituximab or cyclophosphamide. And you should remember that anti-TNF to be avoided in patient who have a cardiac failure or having demyelinating CNS disease. And what is far more important point is that these biologic or target synthetic demand, though will not cure or completely control the disease. They have also limitations that we should keep in mind. So what we measure ACR 20, 50, 70 response, or I would say in a simpler term, a mild, moderate, and significant relief. We get with this biological or target synthetic demand in patients who have inadequate response to methotrexate, only in 60% mild relief, moderate relief in 40%, and significant relief in 20 to 30% of patients. So they are not always that if you start and you will get a relief. So always you have to need to monitor the disease very tightly. And sometimes the biologic can fail, which can be either a primary failure or secondary failure. Primary failure is where when you start a biologic but you don't get a response, that is called primary failure. And when you initially get a relief but then again response start failing, that is called secondary failure, where then you need to change the therapies. Where if you are on biological, then you have to change to another biologic. Suppose if patient is on etanercept, then you need to change it to the either tocilizumab, rituximab, or JAK inhibitors that way. And another common scenario that we see in day-to-day practices, various rheumatoid arthritis patients, which keep on wandering to one doctor to another, like this patient who was initially started on methotrexate, had a mild disease activity of swollen joint count of 2 and more of tenderness. And then she had a partial relief, so she went to another doctor that added leflunomide steroid. But again, she has all joints which are tender. So she moved to another third doctor where she got added to the now tofacitinib. Steroids were continued. Still, she is not getting relief. Where what missed was inquiring about her sleep patterns, headaches, fatigueness, unrefreshed sleep, or memory fog, which can lead to the diagnosis of fibromyalgia, which is a major important factor which can lead to the resistant RA, where actual these patients don't have disease activity or arthritis, they have more of myofascial pain. And this happens because RA inflammation trigger the nerve sensitivity, which result in the central sensitization, and the brain amplifies this pain signal. So these patients usually causes have a persistent myofascial pains, which unnecessarily lead to the consideration that they have a high disease RA activity and lead to unnecessary escalation of treatment. That should be kept in mind. So rheumatoid patients are like straightforward. They have this joint synovitis, wrist synovitis, elbow synovitis, straightforward. Not much of unnecessary symptoms they will tell you. But fibromyalgia patients are like that, carrying the baggage, large baggage, where they have some all other symptoms. They will keep you telling कि इधर भी पेन हो रहा है, वो भी पेन हो रहा है, नींद भी नहीं आ रही है, थकावट हो रहा है. That where you need to identify and don't need to unnecessarily escalate the immunosuppressive. Let's see this last case scenario. This was a 69-year lady which had a progressive hand deformities, and she had a RA factor positivity, anti-CCP negative, was treated with methotrexate HCQ. Here, if you can see, there is a mild ulnar deviation, if you can, and this was her X-ray, which is showing this ulnar deviation of hand. And when she kept on the table, this deviation went away. It become little more of straightness compared to here what you can see. But she didn't had this osteopenia or erosion where with this much of deformities. And she was referred to us to either change to the triple demand or biological therapy. But what exactly she had is a senile Jacquard's deformity, where on applying pressure, this deformity get corrected. That is a corrective deformity, and she didn't have rheumatoid arthritis. So rheumatoid arthritis can mimic in various ways, and that RA factor false positivity is there. So you need to be very cautious before labeling any patient if he's not getting relief with conventional DMARD therapy. So, and how long should treatment be continued? So, we need to maintain a sustained remission for at least 6 months to 1 year. And then we should taper the treatment, not abruptly discontinue. And in tapering, what we should do is first taper steroid, then followed by biologic, and then we should taper down the conventional DMARD therapy. And there is a high risk of relapse after tapering these medicines. And if they develop flare, then we should reinstate DMARD therapies. So my conclusion is think early and act early because you need to differentiate inflammatory from non-inflammatory arthritis, and you shouldn't rely completely on RA factor or anti-CCP directly. We should use a clinical judgment. We should look beyond the articular manifestation in these patients with rheumatoid arthritis. They may be harboring ILD, scleritis, or so many. And we should have a right referral and right outcome because there is advancement in treatment, and we should refer this patient to the rheumatologist. Thank you.
So if there are any questions, the residents can ask Dr. Deepak.
So how will you differentiate in treatment of RA mimicking
So
fibromyalgia
anybody want to
mimicking
ask
the
any
RA?
question?
So what is the treatment option of fibromyalgia which is mimicking like a RA?
Deepak, her question to you is how will you treat fibromyalgia which is mimicking RA?
Okay, so how do you, Dr. Gayatri has asked, how do we differentiate radiological findings between early RA and late RA? Any hallmarks? So the earliest deformities that earliest radiological changes that we see in these patients with rheumatoid arthritis is periarticular osteopenia or marginal erosions, and later on they start getting the joint deformities. Dr. Shomila is asking, RA patient with hilar lymph node should be started on conventional demand meanwhile to rule out TB. So, if it is a only hilar lymphadenopathy and definitive rheumatoid arthritis diagnosis, and if there are no any TB evidence per se, history-wise, fever or nothing, you may start with a simple HCQ and you should evaluate, confirm your diagnosis of TB. If it is not, then we should properly treat it. What are the treatment options for fibromyalgia which mimics RA? Mainly for fibromyalgia, we should counsel the patient what exactly what they are getting, these aches and pain are not because of rheumatoid arthritis. And the treatment options that we have is one is the yoga and all exercises that really helps. Other than that, what we commonly use is pregabalin, gabapentin, duloxetine. These are the commonly that agents that we use in this patient. Dr.
In
Priyanka has
patients of
asked, for patient on
fibromyalgia,
methotrexate who later
uh,
develops ILD, if it's progressive, do we stop methotrexate and start other demands? So it has been shown in various data that methotrexate usually doesn't lead to the ILD. It causes hypersensitivity ILD, but RA per se can cause ILD, the disease activity, where stopping methotrexate we usually continue, but sometimes, if it is a very rapidly progressing, then you may consider stopping or treating the ILD part. But usually we continue methotrexate.
so methotrexate should not be stopped in patients with RA-ILD because methotrexate itself gives a lot of benefits for the joints as well as the interstitial part. Methotrexate lung injury is very acute. It comes very acutely and it mimics like the interstitial viral pneumonitis. And another thing I would like to add with fibromyalgia is apart from the treatment what Deepak has mentioned, you need to have a thorough evaluation by a psychiatrist because majority of the patients are having underlying they are having underlying depression as well because of the chronic disease.
Nice presentation, Deepak.
So I think we can end today's lecture and we
Yes.
meet again.
Yes, sir. Next month we'll meet again on 4th Sunday.
Okay, so we stop here and we join again in the month of November on 23rd of November at 11 a.m. The link will be shared 2 to 3 days prior to the lecture.